Hello, everyone. I'm Dr. Joe Roberson, and welcome to Worldwide Roundtable discussion this morning. I'm coming to you from the California Ear Institute, which is in the San Francisco Bay Area in a town known as Portola Valley in California in the United States. We have a facility here that has an operating room and that also has all of our clinic and postoperative care facilities. And we're privileged this morning to respond to a popular demand to answer a number of questions. The topic of this one will be miscellaneous questions. We have people with us from all around the world, actually, from the central part of Asia, from Middle East, from Europe, Africa, South America, and also the United States. So greetings to you. It's early morning here in California and a beautiful early or late spring, early summer day. So we are going to consider this topic that is one that has a lot of information out there, but also has a lot of misinformation out there. And I hope to be able to clear that up for you. Now, what we've done is, as you have registered, we've asked you to give us the questions that you would like covered today. So I've put together a format of slides, which we'll go through, that will seek to give you those answers. If you have other questions, you can email us, or we may be able to get to some of the text questions or communicated questions through this format. So let me get our slides up and going here. Let's go through a number of questions. Our first one, if you will, is how do you determine if a child is a candidate for atresia repair? That's a good question because not every child is a good candidate. In fact, I think one of the important things to identify in this process is when to say no to this surgery, because there are some children and some adults who do not have the space or the arrangement or the correct anatomy to allow a surgery. Now, we've developed early on this system. This is a system that I published now 12 years ago. When we first started doing the surgery, we realized that there's no real consistency about how to choose candidates. And excuse me, then also there is no good way to compare outcomes because we really didn't know the different variables that people went into surgery with. And this is a result of that. We looked at a huge number of variables, and these are the ones that we came up with. We use the acronym HEARMAPS, and each of those letters stands for a different thing that we evaluate. The first one is hearing. So we need a hearing test for a couple of things. Number one is we want to make sure the inner ear is normal. The hearing nerve is normal. That's almost always the case with Atresia-Microtia, but there are a few selected cases where that's not the situation. The second that has a lot to do with this is the outer ear itself. Generally speaking, the more formed the outer ear is, the more likely a patient is going to be for an ear canal. But there are plenty of people who have very little to no outer ear formation who are candidates as well, but that's a variable. The most important one is the A in atresia. A CT scan is an X-ray that's done that gives us a picture of the bony anatomy of the inner ear. And that CT scan is done at 2 to 2.5 years of age. I like to read all of those myself. I don't like someone telling me what the score is in that, for example. And I have a system where I give points for different parts of the anatomy, like the facial nerve or the middle ear bones or how much space is in the middle ear. And based on our results, looking back on CT scans, we can tell who is a good candidate and who is not. So that's the major determinant of who's a candidate. The other ones are there also: the remnant lobe, how much an earlobe is present, whether the jaw or the mandible is formed correctly. Some people have reduced size of the bones on the same side as the Atresia-Microtia, called hemifacial microsomia. The asymmetry of the face is the soft tissue component of that. And then the facial nerve, its function needs to be evaluated because a decrease in facial nerve function is a negative sign for getting hearing. We still sometimes can, but that's something we need to be careful with. And then there are a number of syndromes, genetic conditions that we need to identify. And the reason for that is many times there will be other organ systems involved. So we need to be sure that we're safe with those children. The two that are the main ones, or really three, is the heart, the kidneys and the spine. Those form about the same time in utero as the ear, and some of the genetic abnormalities that cause Atresia-Microtia also cause abnormalities in those conditions. So the major two are hearing and atresia. Those are the two that we have to get a test for. So you would get a test at home. You can send those to us by email, and then with pictures, we can actually do the other portion of the grading system to come up with a Hear Maps score. If you are someone who likes to read articles, take your phone out and take a quick photo of this one. This is the original publication. We looked at 742 of our patients to determine what were good predictive values or predictive variables for when and how to do surgery. So that's completely our work. No one's done that I don't know of at all in the world. So that's a really important thing I think we've contributed to this process. Now, very briefly, the canal candidacy is if a child has a score of 6 or higher, and the scores that we give are from 1 to 10 when we grade the CT scan. The higher the score, the better the score. So if a child has a 6 to 10, then they have either a good or a very good chance of success. And I'll show you some of that data here in a little bit. Scores of 5 are on the border. We can usually get some hearing in that ear, and sometimes that makes sense if you have bilateral Atresia-Microtia. And under 5, we rarely reconstruct because the chance of getting good hearing with an ear canal is not high. Now, some people like to have a canal to wear a hearing aid in, and that's another process too. But you can see just from that brief description that there's a very individual formula for each patient. So, what we like to do is to get the data with the Hear Maps. We like to evaluate that and give you some general guidelines or recommendations. Then I like to talk through that with you for about 30 minutes on a Zoom call with a translator if we need it, so that we can understand or you can understand what the options are. Now, there are also two times when we will recommend surgery no matter what. One is a cholesteatoma. It happens in about 3% of cases, so 1 in 30 patients, roughly. And a cholesteatoma is a tumor that can form under the skin, and it can be damaging. I have some slides later. We'll talk a little bit more about that. And then occasionally you will see an ear that has an ear infection in it that is causing either a facial nerve paralysis or other problems like meningitis. And sometimes we have to urgently open and drain that ear. So that's also answers the question some people have. It's can you get ear infections in atresia ears? And the answer to that is yes, you can. All right, so this is complicated, but this is what we use as our flow diagram in terms of what to do with treatment. As you see on the left side, the CT scan is the first thing that we get. And then the grade 1 through 5 is we look at, we don't look at an ear canal, we look at another method of providing hearing, and that can be an implantable hearing device or a canal or a hearing aid. And then grades 6 through 10, we do recommend an ear canal. And there are really 4 ways to handle the outer ear. One is that some people, if the child's small, decide to have the ear canal and then wait for new developments. There is some interesting things happening. There are some interesting things happening with cartilage reconstruction right now. So a few people do that. Most of the patients that we have choose between one of 3 options. One of them is reconstruction with a rib graft, where we make the outer ear out of rib, and that is a procedure that usually takes 2 or 3 procedures, and then the ear canal happens after the rib graft. Or they will choose having an ear canal surgery first, and then 6 months or more later afterwards, the microtia repair with the porous polyethylene. There are a number of companies that make this. You'll sometimes hear people call it MedPor. MedPor was the first company that made it, but that's porous polyethylene is probably more accurate because that covers the types of prostheses that all companies make. Or the last option is you can have the ear canal and the outer ear surgery at the same time. And there's some times where there's great appeal to that. Now, what are the advantages of having ear canal surgery to supply natural hearing? And I think this is a great question. And here's why, is because a lot of times children who have single-sided hearing loss, single-sided Atresia-Microtia, in a noisy environment or with their family, they actually function normally. You don't see any issues with it. Where you start to get into trouble is usually when there is a background noise in place, such as a classroom. And those children do well until they get to about second or third or sometimes fourth grade, and then they start to fall behind. Now, here's the unusual thing about this is that the time to intervene to provide hearing to a child so that they avoid that problem in fourth grade is actually early in their life. It's called a critical period. I'll cover that more in just a minute. So the advantages of bringing hearing in early, and we like to go between 0 to 5 or 0 to 10 years of age for that, are the following. Number one is that children who have single-sided hearing loss, uncorrected, have 40% less vocabulary and less complex vocabulary than patients who have bilateral hearing. So the children that have single-sided deafness can do very well, can appear normal. They speak, they have clear language, and they progress, but they are impacted. So they have less development, slower development than people or than children who have two ears working. Here's a study that shows that in the United States, vocabulary has a significant effect on our lives in the standpoint, or from the standpoint of income. In fact, of all the variables that we look at in terms of the timing in life and the things that children face that affect income, vocabulary is actually the highest predictor. So if we average patients in the United States, average the salary or the money that people make each year, who have single-sided hearing loss, they make on average 40% less than people who have bilateral hearing loss. I know these are somewhat harsh statistics, and it's startling a little bit, but I really like to put that out because a lot of doctors around the world will say to patients, I've heard the story thousands of times, they're like, why do you even care about that? The way the hearing is on that ear. Look, he can hear me fine. Johnny, look at me. And Johnny looks at the doctor and says, see, he's fine. So that's true that Johnny can look at you in quiet when you call the child, but it is not true that it does not have an effect on him or her. So that's important for you to understand as parents. The second one, and this is usually the first one that people notice, is sound localization. And what that means is when we're standing out, let's envision ourselves on a soccer or a football field, and someone calls our name, we are very good at knowing where that sound is coming from if you have two ears. A single-sided hearing loss, you don't have any ability to tell where a sound is coming from. And you may see this in your children that when you call them, they kind of turn around and scan the environment to see where you are because they can't tell where that's happening or where the voice is coming from. But interestingly, children who have a single-sided hearing loss go to the emergency room 20 times more frequently than children who have two ears. And the thought is that they don't hear certain things coming, bicycles behind them, a car. They're not adept at certain team sports because of this. So that's an important one. And of all the things that we do as far as getting hearing, this is the easiest one to get. A very high percentage of patients get this with us. This is the big one. This is the one that, for my own children, I would really want to alleviate, is hearing in background noise. As I mentioned to you, when you are quiet with single-sided hearing, you do very well. But when it gets noisy in the background, it is very hard to understand people with single-sided hearing. In fact, if we test people, the understanding drops 40%. So that is a huge impact in children in that third to fourth grade window that I mentioned to you, where we start to see problems. So we actually see a 10 times increase, 1,000% increase in repeating a grade in the United States. And a lot of times you'll see behavioral issues because of this component. Now, here's why that's the case. If you're in a quiet environment and you're listening to the teacher and you're getting the instructions and everything is being understood and you're doing your assignment and going along well, and then people around you start to talk, and then you lose 4 out of 10 words that the teacher is giving you, it is extremely frustrating. What happens is children will sometimes detach. They just go, I can't do it. And we'll sometimes see people that are labeled as autistic or on the spectrum when the issue is actually hearing. We'll see some people, more boys than girls, but sometimes they'll get aggressive and get mad, and they'll get upset with their peers, or sometimes they even become a little violent because they're not getting what they need. So that's a critical factor. I think that's the biggest one, actually, that patients like. When people come back to us, especially teenagers, and I say to them, "What's the best thing about your new hearing?" They'll say to me, "I can hear my friends." And what they are telling me, in a short sentence, is that if you think back when you were in elementary school and you're in between classes and it's so noisy and you're trying to talk to your friends, they can't, they don't get it. But with the second ear, now they become part of the conversation. And we frequently see children become much more social and more adjusted when the second ear hearing comes online. Now, we'll talk about this in the future, but really think important thing for you to notice is that when you wear an implantable hearing aid like an Osia or Baha or Sofono, et cetera. There are a number of companies that make those. It does not improve hearing and noise. In fact, it can make it worse. I did a whole worldwide roundtable on this, so you can find that on our website if you're interested. But that's if the doctor says, "Oh, no problem, we can alleviate that by putting an implantable hearing device in." Wrong. That's not accurate information. So the next question is, what is the hearing critical period of development, and how does that determine when to do canal surgery? Again, very good question. So the critical period in human development is defined as a time that we have to get a stimulus for the system to develop normally. And if you don't get the stimulus, then the brain just kind of shuts that down. It doesn't, it can't go back and pick that up. And two common examples people usually understand. One is we've all seen people who have one eye that's not pointing in the direction. You'll hear it called a lazy eye. The medical term for that is strabismus. And if that eye is not corrected early in life so that the brain can take the two signals coming from each of the eyes and meld them together, the brain will just, in effect, kind of shut that eye off. So the vision on that side just becomes something it doesn't pay attention to. And the same thing can happen to an ear. If it doesn't have sound going through it, then the brain will not form the neural connections that are going on rapidly between birth and 5 years of age. So, if you play this out, one of the thoughts is parents will frequently say, "Okay, I'm going to have canal surgery at 3 or 4 or 5, but should I wear a Baha or some sort of hearing device to stimulate that ear before that point?" I think the answer to that is yes. I can guarantee you it doesn't hurt, and I suspect that it helps quite a bit. We haven't quite been able to show that yet. But that's one aspect of that. So my child is outside the critical period. How old is too old to have canal surgery? All right. So I have there we'll go. Sorry, went too far there. I'll just answer this one. So we've done surgery in people of all ages. My oldest Atresia candidate or person that received it was 64 years of age because she started to have hearing loss in the other ear. She wanted to try to avoid a hearing aid. And then we frequently do surgery in the 20s and 30s. The 0 to 5 is the sweet spot. 0 to 10 is very good. And we do surgery up to about 35 or 40. And if you ask people during that period of time, "Are you glad that you had the surgery?" Even a 30-year-old, they'll come back and say, "Yes, I get benefit from this." So there is still benefit quite old. But if you say to us, "What's perfect? What would you do? What's the ideal?" Then you know that earlier is better in terms of that. So here's the question I alluded to earlier: is what's the difference in an implantable hearing aid and a natural hearing canal? And this chart helps us. Again, there's a worldwide roundtable on this. The ear canal gives us directional hearing and hearing and noise. We've already covered that, whereas the implantable hearing device does not. The lifetime cost of an ear canal is less. The implantable hearing device it has an external component that is about 6 to 7,000 US, and typically that needs to be replaced every 3 years or so. So if you think of an 80+ year lifespan, that's quite an expenditure over time. The sound quality is significantly better in an ear canal. The devices, implantable devices, are good. You can understand them, but they do sound a little machine-like. Sometimes the child will say it sounds a little like Mickey Mouse or a cartoon character to me. The advantage of the implantable hearing device is that it is not hard to do that surgery, and it's one that will give consistent results. So there are a lot of places that don't do canal surgery who will offer the implantable hearing device. We typically use them in patients who are not candidates for an ear canal. They're way better than not doing anything. But if you ask me what's best between a canal or implantable hearing device, the canal in appropriately selected patients is better. The other thing is that the implantable hearing device have some kind of neat connectability issues. For example, you can connect to your cell phone directly to the device so that you hear that where other people don't hear it. You can connect music from your phone to the device and listen to music, and other people don't know that you're doing that. And both of them, the last category there, require care. The canal requires cleaning. I'll show you some data on that in a bit. And the implantable hearing device obviously requires tuning. It requires batteries in the external component, and there is the replacement factor, which I have mentioned as well. All right, so I've heard a lot about outer ear prostheses breaking, and what are you doing about that problem? This is a very common question that we get with emails and other things right now, and let me show you what I mean. So the next few slides are photos of surgeries that were done by plastic surgeons that we used to work with. These are not surgeries that I've done, and this is what's happening actually now in up to over 30% of patients. So it's quite an issue. And we see that the implant, the porous polyethylene or the MedPort implant, is actually breaking. This one looks pretty good. It's not too clear that it's actually broken, but let me see if I can. There, this one shows you that you can see much different how at the top of the ear there's a step off, and then on the back left of the ear, around 9 o'clock, if you were looking at a 9 o'clock on a clock face, you see a red bump, and that's where the implant is actually starting to come through the skin. That's very concerning because if bacteria get through the skin and into the implant, then the outer ear becomes infected and then we have to remove it. This is one that we would say has to be replaced fairly quickly. Here's another one. You see the back part of that implant is just folded inwards. This one doesn't have any skin breakdown, which is good, but that implant is broken. And
Now
what
you're
did we
going to
do?
see
Well, quite
some
a while
drilling in this
ago,
implant.
we began to
So
realize this was
this
an
is the
issue,
drill we
and
use in the
I
operating room. It's a
worked with a
two
company called
millimeter
Supor
burr. You can
to
see that
make
there. And
a
what
new
happens is
implant.
this
We've gone
device
through
here
about
supplies
8 months
power
and
to
four
the
different
drill,
prototypes. We
and the
carved these
burr
into the
itself will
sizes
allow
that
me to
we
sculpt
wanted,
the
shapes that we
implant
want.
into
And
what I
the
want it to
implant is
be.
much more secure. It's so far we have not had one that has broken. We've been using that for well over 6 months now, 8 or 9 months actually, and I don't think we will. The implant is, I think, a little more natural looking with projection. So I think that's been an improvement. Here's a photo from the operating room of an ear that was an implant that was removed, and you see there and there's a fracture. Now, if I grasp that and move it, you can see that that part of the ear is just very flexible. So these are the this is actually the boy that had the posterior ear flipped backwards. And here's another video from the operating room. You see the
This is
new
the old
prosthesis
prosthesis with
on
the
the
thin limb, the
left
one that's broken
and the
here
old one on the
and
right. So
here
the one on the right,
and
there
here.
is
And this
sort
is
of a
where
weld.
the
You see right
weld
there. The
was
plastic
made.
surgeons would
And there was also
frequently
a weld
melt
made there. Both of
a
those
part of the
failed.
device to try to make
This
that
prosthesis has an
stronger.
open area. It
And in
also
this
has an
case, it
open
didn't
area
work
back
at
here.
all. And the new
The new
implant itself
prosthesis is
does
solid.
not have those holes. It's
It doesn't
much
have the holes or the
sturdier.
openings there.
And in just a
And the
second, you'll
implant
see that I'll turn
also
it sideways.
has a
So it
very
has
firm
a component
rim.
that
So this
allows
rim
or
would be
pushes
very
and
hard to
keeps
break.
pushed out the
It's made of the
posterior
same
rim, so the
material.
ear typically
It
doesn't
also
come
has
back
a
against the
bigger
head as
portion
easily.
in the back
Whereas if
that
you look
keeps the
at
implant
the implant
from
that has been
pulling back
removed on the right
and
side, that
becoming
does
too
not
close
have
to the
that
head.
component.
This implant
And
does
that's why
not.
in this
It
situation,
has a
I think
very small
we saw the
area
ear
in the
pull
back, as
back
you can
pretty
see.
severely against the head. So that implant here's a patient who has that implant. It's called the Roberson combined Atresia-Microtia prosthesis. She had her right ear done, and you can see that that has excellent symmetry, height-wise, size-wise. She had surgery about 3 months ago now, I believe, 4 months ago actually, and that ear is doing quite well. And that one, I believe, would be very hard to break. A lot of times we get questions about just to see photos of patients. I'll send you to our Instagram page. Get your phone out and take a photo of this if you want to. We post a lot of pictures of their patients who have had the surgery. I have seen probably, oh my goodness, I would say more than 50 patients now who have had implant fractures in the last from surgeries that were done in the last 3 or 4 years. So unfortunately it's a common thing that we've had to replace those. So there's two parts to this. One is how do we fix what's there, which we can do, and then the second one is how do we prevent that in patients going forward. And I think this implant will go great distances and be able to alleviate this problem. All right. So next question is: can an ear canal and outer ear be reconstructed at the same time? And what are the differences in either one or two procedures, separate procedures or combined procedures? So in 2008, in a young boy who was adopted in the U.S. from China, we did the first combined Atresia-Microtia repair at the California Ear Institute. And since that time, we've done about 850 or so at the same time. We also do surgery where we do the ear canal, and then the outer ear is reconstructed 6 months or more later. That's, remember, our flow diagram. That's the other option. And then a much less common option is that we will see patients after rib graft reconstruction of the outer ear and then perform the ear canal. That's probably, oh, I would say it's 1 out of 50 of our patients or even less. It's a very small percentage now. So most of the patients that we see are choosing to have the porous polyethylene reconstruction. And it seems to be, which is understandable, that if you're from a long distance, if you're coming here from Russia, for example, having both the canal and the outer ear done at one visit has some advantages. So the next part of the question is that what are the differences in one of the, or two procedures? There are two that I can find. One is, and this is, by the way, a patient who had combined Atresia-Microtia repair. This is in the operating room. They're still asleep. So we just put the prosthesis in, the new Roberson Camp prosthesis. And that one is, there's the post-op. Oops, sorry about that. That was very quick view, but that was 2 weeks post. Let me see if I can maybe go back to that for you. Yeah, here we go. So same patient, 2 weeks after surgery, you see in the middle of the sponge that's brown is in the ear canal. We're still holding the skin graft and the eardrum repair in place. So that comes out at about 2 weeks, and then the patient is able to hear for the first time. But that gives you a look at what the outer ear is looking like. So my first question when we started doing this combined surgery is, what's the difference in hearing between the two? I don't think for convenience it would be worth trading a good hearing, for example. So we looked at a large number of patients that we had done and looked at the outcomes in terms of the hearing. And here are the averages. And these are for people who only have an ear canal. And there's some people who have normal outer ears and a bad or an atresia ear canal. So we can repair that. The second category is the canal, then the MedPOR, the separate surgeries. The third category are people who had both the canal and the outer ear at the same time, the combined Atresia-Microtia repair, or the CAM. And then the last is the rib graft. The only difference between those was the rib graft was slightly worse in terms of hearing. So there's really no reason to decide for separate or combined as far as the hearing goes. This next one shows you the one difference that is present. If when we do the surgery early on, or when we did the surgery with CAM surgery, we put the ear in place. We did not do anything except sutures to suspend it or to hold it in place. And what we found over time is that gravity caused that ear to actually move. So the ear would come down. So our solution was something called a periosteal leash. There's a dense tissue along the bone that I was able to elevate. We wrap that around the implant, and then that secures the implant and keeps it from dropping below. That's really important. I would say I've heard that there's been some, let's just say, maybe theory that the plastic surgeons have put out that that's the reason that implants are breaking, and that leash is not the reason. The reason is the implant itself. But look at this. Look at this photo or this video here. And you see how when I push up, you can now see the ear canal. So that ear has come down and completely closed the ear canal. Obviously, hearing is the problem. So we had to go back to the operating room and free that implant up, move it up, and then suspend it with sutures in order to expose the ear canal. Next question is, how long have you been performing ear canal surgery and outer ear surgery, and what countries do you visit to do surgery? So, first part is that we don't do surgeries in other countries, and I'll tell you why. Is that the post-operative care for patients is very important. You have surgery with us and stay, depending on what surgery you have, usually 3 or 4 weeks. And during that time, we have very important molds. You saw the one picture with the sponge in the ear canal, and those have to stay and be very stable for a period of time before you can travel, like airline flights and that sort of thing. And what I just don't feel good about going to a surgery, going to another country, doing surgery, and then leaving the post-operative care to someone that really may not know exactly what to do with that. So we haven't done surgeries in other countries. I've been performing ear canal surgery since, oh, I think my first one was in the early 90s, so quite a while now. And I had the great privilege of working with the best rib graft surgeon in the world at that point in the US. His name is Bert Brent, who was actually in my office then. And a large number of surgeries were done with him as the outer ear reconstruction. And then about the year 2000, we began to see that the PPE reconstruction had advantage over the rib surgery, and patients began to choose the PPE surgery. So we switched, and I started doing more of the outer ear surgery. Um, there's a long list of things we have brought as far as innovations, but we were the first one, or I was the first one to do ear canal surgery before outer ear surgery. That was our first change. And the reason we did that is to take advantage of the critical period. Patients who had selected ribs, usually they were, in fact, their average time for ear canal surgery was 12.6 years. So now you know that that's outside that really important period of brain development. And we didn't see vocabulary and hearing and noise and other types of development as good as we do now when we do surgery earlier. So then from that point in 2008, we did the first combined ear canal and outer ear surgery. And since that time, we've done the number that I mentioned to you since, so about 850 or so. So we've got quite a, probably the world's largest experience, absolutely the world's largest experience with the combined surgery, and probably of all types of surgery, really. And what is the chance of success for hearing of ear canal surgery? That's a key question. And when we talk on a Zoom talk, that's something that we would give you is here's what we think your chances of getting normal hearing are. Now, almost every person with canal surgery gets improved hearing. But what I want to see is hearing in the normal range. And by normal range, I mean on a hearing test in the 0 to 30 decibel range. The best surgical results that I've ever gotten are still not as good as a normal ear. And I believe that's because the middle ear bones are slightly malformed with Atresia-Microtia, but they can be very close. Patients can use the phone, they hear whispers on that side. But if they take the phone and move it from right to left ear, they always say, yeah, my normal ear is a little louder than my reconstructed ear. But the CT scan is really what we rely on. So here's data in terms of 24-month follow-up in 70 cases. And again, 0 to 30 decibels is what we're shooting for. And if you have a CT score of 8 to 10, then you have an 80% chance of coming into the normal range. If you have a CT score of 6 or 7, then you have a 67% chance of coming into the normal range. And again, those the 20% in the CT of 8 to 10 get improved hearing, and the 33% in the CT score of 6 to 7 get improved hearing. One question that sometimes comes up is what's the chance I need to wear a hearing aid in this ear after canal surgery? And that number is about 10%. So 1 in 10 patients will need to use a hearing aid even though they've had ear canal surgery. The higher the score is, the less of a chance we have of needing a hearing device. This is a patient who says, my son scores below a 7. Can we still look to safely do an atresia repair in the hopes of giving some hearing without a hearing aid? So the first thing I would say is I would like to see that CT scan, please. I have looked at CT scans before, and I didn't agree with the score. So I don't know what score, sounds like maybe a 6 or 5 that another doctor gave. sometimes if they gave a 6, I may give a 7, or if they gave a 7, I may give something lower than that. But let's assume that this child has a 6. The answer is yes, we can. In fact, with a score of 6, our goal would be to try to get normal hearing in that ear. A 5 is a borderline case. So that's something when I look at the CT, I can give you some more input on. But remember from the last slide, a 6 or a 7, we have a roughly two-thirds chance of getting normal hearing in the ear. Next is, what is the waiting list like for surgery, and how long after you see the CT scan could surgery be scheduled? So we are booking. We have probably 90% of this year booked. There are a few spaces left. We have a waiting list for next year. I think there are about 40 or 50 patients on that at this point in time. But it depends a little, pardon me, on what the surgery is that we're contemplating. The ear canal surgery alone is easier because that takes me about an hour and a half to do that surgery, whereas the combined surgery takes me about 6 or 6.5 hours to do that. So obviously, the shorter time would be easier to find a spot. And then after the CT scan, again, I like to see that at 2 or 2.5 years of age. The earliest we like to do surgery, except for some instances like cholesteatoma and other things, is at 3. Now, not all 3-year-olds are ready for that psychologically. Sometimes they're not big enough. We like to have them at 14 or 15 kilograms before we do the surgery, and sometimes we'll wait another year just to let them mature. But if you have a CT scan at 2.5 years, the earliest that we would be able to do the surgery would be 6 months after that. And what is the best age for surgery? How long is the healing process? How long is the surgery? And what are the major complications? So the best age for surgery, I think we've answered. Earlier is better. What I would shoot for in my own child, or now my own grandchild, would be in the 3 to 5 year age range. How long is the healing process? So you stay with us if it's a canal surgery for 3 weeks, and by the time you leave, you're 90 to 95% healed. We typically wait another 4 to 6 weeks to resume water exposure, like swimming in the bath and that sort of thing. But at 4 weeks or so after surgery, then the child can run around and jump and play and act normally. We try to keep them calm and settle down while they're here. That's the parent's hardest job, honestly, for a young child, to keep them from running and playing. The surgery, how long the surgery is, I mentioned that. One other factor on the healing process is when we first remove the packing in the clinic. If you think back to that brown sponge in the patient you saw that was 2 weeks post-op, when we first remove that sponge, then the child can get hearing on that side really for the first time. It's a pretty magical day, actually. But the healing continues and the hearing improves for up to 5 months after surgery. So what we'll ask you to do is, if you had surgery, for example, and you were leaving today here, right around June 1st, then we would ask you toward the end of 2025 to get a hearing test at home and then to send that to me, because that really tells us where we are and how we're doing as far as the healing and the hearing goes. And the major complications of this type of surgery, I'll give you 2 slides here that list each of those. One is for the outer ear, and one is for the ear canal. This one is the outer ear. We've covered implant fracture. The next most common one is that when we perform the surgery, the tissue flap that covers the ear goes over the prosthesis, and then on top of that is a skin graft. And there are times when the skin doesn't heal correctly. We think most of the time there's poor blood supply in a part of the flap, and we have to do a small revision. That's almost always done before you leave here. That can happen. The tissue that we bring down from under the skin to cover the ear is close to the nerve that supplies the forehead on that side. And in a very small percentage of cases, the two are very close, and we'll get a weakness that is usually transient. It usually comes back. It can be permanent, but it's usually transient in the forehead. Implant displacement, I showed you that, and that really has been mostly a problem with patients who did not have the periosteal leash when they had the combined surgery. We've proven that really clearly, and I've heard some surgeons have stopped using that leash, and it makes me concerned because we're going to see the same thing happen over again. Implants are going to come down. When we lift the tissue from under the scalp to cover the ear. We come close to the hair follicles, and sometimes you'll see that the hair follicles will be stunned, I guess is the right word, partially injured, and the hair will fall out in a little area. But that almost always grows back. But it may be a month or two before hair comes back. So that's another one. And then lastly is we have to preserve the blood vessel to the flap in order for it to supply blood to the flap to keep the skin graft alive. That's a very delicate part of the surgery, and there's a possibility of injury to that vessel. We've had that in a handful of cases, and we can repair it and reconstitute it in the vast majority of those. But those are the lists for the outer ear. Now, here is the list for the ear canal. And this one has both the worldwide percentage and then our percentage on it as well. So infection is really rare. That's great. Any surgeon or any surgery has a chance of infection, but that's been a very unusual complication with us. The eardrum can move after we get hearing, good hearing, and then that can decrease the hearing later. When we first started doing this, that was a big problem. That was the second most common problem. And I've developed a technique where we now anchor the eardrum to the middle ear bone. So that's drastically cut down that incidence, pardon me, of patients who have had good hearing and then later it drops off. So that's called eardrum lateralization. Stenosis or narrowing of the ear canal was by far the most common one. The hearing loss, excuse me, the stenosis was up to a third of patients actually in the series around our whole series around the world at that point in time. And I'm really pleased that we've made some great strides with that. We use specific surgical techniques, specific skin graft techniques, and also we ask you to wear a mold in the ear canal for the first 4 months after you go home when the child sleeps. So at night you put a drop of antibiotic in, you put the mold in place, and then in the morning you take it out. And our stenosis rate now is actually under 2%, which is fantastic. Anytime you work on an ear, you can cause an injury to the inner ear. Worldwide, that's 2%. That's less than 1% for us. The next one is one that everyone sort of dreads and thinks about is that it's possible to injure the nerve that controls the face on the same side as the surgery. And I've heard some recent examples of that among experienced surgeons. But fortunately, in my series to date, we've not had that issue. We use really 3 mechanisms to keep it safe. Number one is mapping it well on the CT scan so we know where the facial nerve is. Number 2 is we use a monitor in and during the surgery that if we're getting close to or irritating the facial nerve, the muscles of the face will twitch. That can be a really micro twitch you can't really even see. But the monitor picks up that twitch and then sounds an alarm to let us know that we need to be extra careful. And then the thing that matters the most, honestly, is experience. You kind of get to the point where you know where these are. It's certainly a complication that could happen to us. I don't mean to say that, but those are the ways that I think we keep that number at 0. When we drill the ear canal, we put a skin graft in the ear. And in some cases, about 2%, that part of that skin graft won't heal well. I think what's probably happened is the child's bumped it, or maybe the packing has been jiggled and it kind of shears where the skin graft was attaching to the bone. And we have to go back and put a little piece of skin to cover that. And this is another question that's coming up in a few minutes here, but the question is, what's the chance of long-term hearing problems? And we've had a drastic change in our technique steadily over the last 20 years. And we have, in the earliest cases that I've done now, we've had about 30 years of follow-up. It's a complicated statistical analysis to try to figure that out. But I believe where we are, if you add up the complications above, it's under 10%. But if you think, okay, these children have to live with this for another 50, 60, 70 years, that number is going to go up naturally over time. So I think that number is probably right around 10%. About 1 in 10 patients will need revision surgery. And there are times when normal things happen to an ear, like an ear infection causes a hole, like it can in a normal one. Or we've had a little young man that, or not little, but a teenage patient that was surfing and got hit by a wave and dislodged his eardrum. We did more revisions, for example, before we started the new technique to keep the eardrum from moving off or lateralizing. But I think that number is right around 10%. That's an important thing I think to think about as a parent. Now, question: what are the chances that hearing achieved with a canal has stable for many years, and what research? So I just answered this one. Uh, we certainly track our patients and look at that. There are very few practices that have the ability to answer that question because the average ear specialist sees one or two of these cases a year, and they typically don't operate on them anyway. So we have the database to answer that, and so far. We'll keep monitoring that. That's very important to me because the techniques that we use, we want to refine those to reduce that number as much as possible. But 10% is what we're thinking now. So here's a good one: is how do you know how big to make the outer ear? So if you have a 3-year-old that's coming in for reconstruction of the canal and the outer ear on the other side is going to grow. Right, the prosthesis that we put in place doesn't grow. The early there's some research done. We didn't do this, but there was research that look at the size of the ear. And here's that chart based on age. So a couple of points. Number one is that your ear's fully grown at 18. So that's 100%. It's going to stay at that point. But by the time you're 5 years of age, it's 90% grown. And by the time you're 3 years of age, it's 88%. So based on the age of the children, we know how much to add to the other side in terms of making the outer ear. So if we did surgery on a 3-year-old, for example, and we had a 39 millimeter ear on the other side, and we add 12% to that, we add on average about 4 millimeters to the length of the ear. So when the ear's first done, the new ear will be slightly bigger than the normal ear in the case with unilateral. And then as the child grows, the two will normalize. So that's a good question. And that's research that was done, 35 years ago now. And you see what just came on there is the rib graft we typically do between 6 to 10 is the earliest we can actually do that. And then the canal is done at 3 years of age. Okay, how is the prosthesis attached and what maintenance is there after surgery for either the canal or the outer ear? So the outer ear will need cleaning more so than a normal ear. Normal ear needs cleaning too, but the skin will build up a little. You'll take a wet washcloth or sometimes a wet cotton swab and sort of clean in the crevices, once a month, once every 2 weeks sort of deal. But that's really all that it needs. We talked about how it was attached with the leash, so we'll go over that one again. But the ear canal does need care over time, and here's what happens. These are one of my children, and I brought them in and put this little black dot on their eardrum. I think you can see in the top left, you see the black dot, and then took a picture about 2 weeks later. And you see it started to move, and then it took a picture 3 or 4 weeks later, and now that black dot is up on the ear canal. So this is a normal ear. So the normal ears are self-cleaning. The skin grows in a circular pattern from the eardrum all the way toward the outer ear, and it brings out the debris. The skin grafts that we use don't have that capacity. So the skin that sloughs or that gets formed on the surface of the skin, and skin in our whole body makes new cells all the time, and those cells just fall off as we are going about our daily business. Those can build up in the ear canal, and it can actually cause infection or blockage of hearing. So they have to be cleaned. In the year after surgery, usually it's 3 or 4 visits. The next year, it's usually 2 visits, and then usually it's once or twice a year. It takes about 5 minutes to do. It's not painful. And this next slide here shows you ear cleaning video, so I'll let that run for just a moment. Takes just a minute to start here, I think. Yeah, let's see. There we go. Okay, now it's going. So this is 5 months post-op. They're in our office and under the microscope. They're in a chair, like a dental chair. I think you can see that little skin buildup. See how it's forming on top of the new ear? So with a delicate instrument, we just remove that. The child can sometimes hear it, but they don't feel it. Doesn't hurt them. And then we will very carefully, over a few minutes, remove that extra skin. The ear canal is, you can see that it's very healthy. There's a little debris there just to the left of the instrument. We'll get that in just a minute. And then as you look straight down, that's the new eardrum. And you may get the impression right in the middle of that eardrum, there's almost like a little bulge. Those are the middle ear bones where we have attached, right in there is where we've attached the middle ear bones to the eardrum. So if when this child came in, they'd have a little reduction in hearing because they'd be a little muffled because that debris would be on the surface of the skin of the eardrum. So now that we clean it, that eardrum is free and the hearing comes back up. So that's what needs to be done at home. Okay, we've got what about 10 minutes left, so we'll keep going as long as we can here. If my child is currently using Baha implants, can the canal be opened and/or the outer ear reconstruction? Answer: yes, if the CT scan is appropriate and the hear maps grade say that we have good chance of success. We can work around the Baha implants. And for those of you that don't know, Baha is a type of bone conduction device. There are two types. One has a post that comes through the skin, the hearing aid connects to, and then the other is an under the skin magnet that a magnet outside can connect to. I typically don't remove the Baha when we do the ear canal component. If the hearing is excellent and if it's stable, then sometimes patients will want, particularly the posts removed, which we can do. But yes, that is possible to do canals after a Baha has been placed. Here's a good question. If the middle ear bones are very malformed, can you reconstruct them? So when we first started doing the surgery, I think overall ear surgeons around the world, this is the procedure we got the worst results with, to be frank. And we really, in some cases, couldn't understand why. We'd look at the ear canal, the eardrum, everything went perfectly. We connected to the middle ear bones, and we would get a postoperative hearing test, and it would improve, but it wouldn't come into the normal range. So we started to theorize there could be something very small wrong with the middle ear bones that we didn't realize. And one of my trainees, one of my fellows, and I looked at that with a tiny microscopic camera that we could put down the ear canal. And we found that in just over 30% of cases, there is a malformation in one of the joints between the middle ear bones that was causing that problem. So then the next question is, what can we do about it? And we've come up with a number of prostheses. Here are these prostheses that are made of titanium that we can use to reconstruct either that connection or sometimes even all of the middle ear bones. And those work very well. They sometimes get phenomenally good hearing. In fact, sometimes some of our best hearing is with the prosthesis. Sometimes we'll know that's the case going in with the CT scan. We'll say, there's probably a problem with this joint, but that joint is about 0.3 of a millimeter in size. So I never know if the joint is completely normal until I actually see it under the operating room microscope. It only takes a moment to know if it's normal. And if it's abnormal, we actually have a system of grading those now. If it's mildly abnormal, we typically will not reconstruct with these prostheses. If it's moderately or severely abnormal, we'll go ahead and do that reconstruction at the first surgery. So there are times where we'll do the surgery. We will see that the joint's not normal. We'll wait and see what we get. And most of the cases, 90% of the time, we're in good shape. But about 1 in 10 of those that have the mild formation, we don't get enough improvement, and we actually will go back and do a prosthesis. So I think we've refined our understanding of that, which is fantastic because some of these patients, if you didn't use a prosthesis, would never get the hearing that we want. So I think this one we've answered mainly. The chance of closing ear canal is about less than 2% now. And here's what I like is if the body is trying to narrow down. In some patients, some nationalities in some regions of the world, they make stronger scar than other regions. When you're using the mold at night, if the body's trying to narrow or close it down, it starts to get to be hard to get the mold in. And I ask patients to call us. We actually send you home with an emergency pack of medicine, for example, for several things, but one of them is for this. And if it's starting to narrow, there's a cream that we can put on the mold that actually turns off the body's scarring mechanism. So we can relax that before it gets so bad that we'd have to do another surgery. It's rare for us now to do a surgery for stenosis. So we don't have it completely fixed, but we've got control of that one pretty good. Here is that mold that's in place, and that's made in our office before going home. The medication is impregnated in that blue mold. You go home with that, keep it at the bedside. Again, put it in at night before the child sleeps, and take it out when they get up in the morning. Okay, what is a cholesteatoma and how do I know if it's present? What do we have to do about it? This is one that not all doctors and not all patients know about. A cholesteatoma is it's a non-cancerous tumor, but it's a cyst of skin that forms in the ear when the ear was trying to form, and they can be silent. You cannot know they're there. They can, like this one, grow through the skin. This is a little girl from Australia that we knew had one. We were waiting for her to get older, but it actually grew to the point that it started coming through the skin. The worry with these is that they will grow silently and actually can enlarge under the skin, and then can eventually erode into the inner ear or the brain, causing meningitis. So they're life threatening. Again, only 3%. And the only way to know whether they're present is to do a CT scan. So we highly, highly recommend everyone have a CT scan before any sort of treatment plan is initiated. Here's an example of what they look like. This is from the operating room in a right ear. That's where the ear canal should have been. And you can see there the debris, the skin debris within the cholesteatoma. And we go on and remove that. So in the interest of time, we won't show that whole video. Sorry not to warn you that that was coming there. Again, this is our Instagram page if you want to see some of the stories and pictures, videos, and testimonials of people who have had the surgery with us. You've got our website address there as well. Here it is again if you need it a third time. And our email, which goes to all of us, is Atresia-Repair@CalEar. If you need help, if you can't find what you need on the website, or you need us to help you walk through the process, please send us a note. That goes to me. It goes to our PA, Haley, who is my daughter, by the way, and to our nurses. So all of us get those emails, and then we will respond to you to help you walk through the process. It takes time to get the data together and to educate yourself. Here maps, for example, it takes us a few data points to look at, to fill that in, and then to be able to give you that information. Okay, so I think that we are at the end of our time, and I think that we've got hopefully you've got some new information that is very helpful to you. I know that's a bit of a smorgasbord of the different things that, different questions, but these are very good. We had the request to have a general one of these as time goes by. Stay tuned. We may add other topics as well to give you further information. Thanks for your attention today, and I wish you the best. If we can help you, we're happy to. And thank you for your attention and for logging on today. So we'll sign off at this point. Take care. Bye-bye.